All right, we've talked about ventilator settings. Now let's talk about some ventilator modes. Remember, really all there is, these five things. We've got rate, we've got volume, we've got some pressures to monitor, be aware of. We've got flow, that I/E ratio, and we've got oxygen proportionality, oxygen delivery. We've got our FiO2. So I've got these five things. Seems pretty straightforward, but how do we deliver these five things is what happens when we get into our ventilator modes. So we're going to talk about some common modes. There are probably a couple dozen different variations of all of these, but these are the big ones. First one we'll talk about are non-invasive positive pressure modes. These are CPAP and BiPAP. You're probably pretty aware of CPAP already, so we'll cover that. Then we'll go over BiPAP and how that differs from CPAP just a little bit. We'll get into once our patient is our non-invasive positive pressure. Those need spontaneously breathing patients. Those aren't necessarily vented patients, but our vents can do those modes. Once they are vented, sedated, or paralyzed, or what have you, they've got an ET tube in, and we are breathing for them via the vent. We've got assist control. We've got SIMV, or synchronized intermittent mandatory ventilation, and we've got PRVC, pressure regulated volume control. And these modes just get back to those five things. So rate, volume, pressure, flow, and oxygen, and how are we delivering them. First of these modes is CPAP, or continuous positive airway pressure mode. It is, again, a non-invasive mode. We need a spontaneously breathing patient. We need a patient who can maintain his own airway, patient who is alert, conscious, can follow direction for this mode. This is all about PEEP, our positive and expiratory pressure. Typically for CPAPs, we're going to start at a PEEP of 5 centimeters of water and kind of slowly work our way up to usually around 20 or so, depending on our patient's need. So this CPAP, the C in CPAP, is continuous, so this is all about continuous pressure. It's like sticking your head out outside the window going down the highway, right? And that is continuous airway pressure. BiPAP is a lot like CPAP. Again, it is a non-invasive mode, needs a spontaneously breathing patient to maintain his own airway. The big difference here, and really the only difference between BiPAP and CPAP, instead of a continuous pressure, we have this variable pressure. So we have an inhalation pressure and we have an exhalation pressure. So on inhalation, we're giving a little extra oomph into the airway. So these patients have airway resistance issues, right? So they need a little bit more airway pressure. So we've got an inhalation pressure, then we've got an exhalation pressure. We've got that PEEP still going to keep those alveoli open. Our initial settings, putting patients on BiPAP, we're giving them an extra 10 centimeters of water support on the inhalation side, on that airway pressure side. And then we're usually starting at 5 centimeters of water for that exhalation pressure, which is our PEEP. So a little bit of extra help on the inhalation, on the airway pressure, and giving some PEEP support on the exhalation. Typically, when compared to CPAP, BiPAP is tolerated a little bit better by patients. So if you have the option, most 911 ambulances just have a CPAP machine on it, but if you do have the option, if you've got a vent on your truck, right, and that's how you use CPAP, and it's got a BiPAP option, I would go with BiPAP first and see how your patient responds to that before going full on into the CPAP mode. Okay, those were our non-invasive modes, our CPAP and our BiPAP. Let's get into our invasive mode. So now we have an intubated patient and we need to breathe for them. So the simplest mode there is on your vent is going to be your assist control mode. And this is all about how do we initially inflate our lung. So when going into an assist control, that's what we're thinking about, and that's how we're coming up with our settings, is how do we want to initially inflate my patient's lung. So under assist control, got a couple ways to initially inflate that lung, and I've got pressure control. We can control our pressure. We've got volume control. We can control our volume. Assist control will respond to intrinsic breath. So we've got a sedated patient, but not paralyzed, and they take their own breath. It will respond to that. But with assist control, which one am I controlling, pressure or volume? Under a volume control, under this assist control, if we set it to a volume control, we're setting a number of breaths per minute. So we're breathing at 12 times per minute, and we are setting, let's say, 500 mils per breath. And that vent will deliver 500 milliliters per breath, no matter what. So what we have to do is monitor airway pressure here. So there could things could go wonky with airway pressures and with our pressures. So your vent is delivering a set volume per breath and delivering a set amount of breaths per minute. Again, this assist control will respond to intrinsic breaths. If your patient does initiate a breath, takes a little, maybe even like a little guppy breath in, the vent is going to kick in under this mode. Is going to kick in and deliver a breath at that set tidal volume, that set VT. So if we set it at 500, your patient initiates a breath, it's going to deliver it at 500. So under assist control, if we're doing volume control, just know that each breath is being delivered to a specific volume, and that's how the vent knows it has inflated the lung, and we need to monitor our pressures. Under pressure control, here's a situation where we can control that airway pressure. So we can set an airway pressure and say to the vent, you deliver a breath up into a certain pressure, and when you hit that pressure, you stop giving that breath. So so here we need to closely monitor volume. So this isn't a totally common mode, but for some patients they respond well to it. So we're giving a breath based on airway pressure. So let's say we tell the vent to deliver a breath up to 20 centimeters of water of airway pressure. So we need to monitor the volumes, both tidal volume and minute volumes. So that was assist control. That's the simplest of all of our vent modes. The next we'll talk about is pressure regulated volume control, or PRVC. So pressure regulated but volume controlled. So we're regulating pressure, right? But we're controlling volume. So our assist control, which one were we controlling? We control pressure, we can control volume. Here we're controlling volume, but we're also setting some pressure boundaries for the vent. So it's assist control with just a couple extra little boundaries on the vent. The patient here can breathe in as much as they want, and with each breath, the vent will assist it and give them that volume. So if you've got a patient who's just sedated but decides they want to start breathing from 12 times a minute to 32 times a minute, the vent's going to let them do that, and the vent is going to assist and give a full breath every single time the patient initiates a breath. So we need to watch that as well. So we're pressure regulating, but we're volume controlling. We've set a volume, but then we've set some pressure kind of guidelines and boundaries. So our pressures are adjusted to meet our volume goal for each breath. Last mode we'll talk about is synchronized intermittent mandatory ventilation, or SIMV. This is my go-to every single time, no matter kind of the status of my patient, because SIMV is a mixture of assist control, which is our simplest one, and it's a mixture of that plus some pressure support. So it's kind of PRVC, it's kind of assist control, all put into one. It will monitor minute volume on its own and give you some alarms if we're going too high, too low. So it's monitoring that on its own. It still allows your patient to take intrinsic breaths, take their own breaths. So if you've just got a sedated patient, they're going to take their own breaths. But if you say in this SIMV mode, I want 12 breaths per minute, and your patient tries to start breathing faster than that, it's going to let your patient breathe. It's going to let your patient take in some ambient breaths, but it's not going to support them. It's not going to give them a full breath like a PRVC mode will. So it's going to let your patient breathe in between. It may or may not support it depending on if it's time to give a breath or not. And with it monitoring minute volume, if your patient starts breathing faster than you've set your vent to do, it's going to let your patient breathe. And it's not going to deliver any breaths. So it's going to monitor all that for you. The other advantage to SIMV is it doesn't breath stack, right? So PRVC, you take a breath, it's going to deliver a full breath to your patient. And it may not be time for another breath. SIMV is going to calculate when it's time for another breath. So if your patient is breathing in between the breaths that it should be delivering, it's going to cancel its own delivered breath. So no breath stacking with SIMV. So these SIMVs, like I say, is my go-to. especially for patients who are just sedated, they're not fully paralyzed. If you have any questions, comments, concerns, or cuss words, please let me know.